Hello, everybody. My name is Tyler, and I'm going to be walking through these slides for this presentation. The reason why I decided to do a video rather than just putting the slides out for this month's training is because there's some slides here that have a bit of information that could use some extra explaining. And rather than just finding a few videos and throwing them in, it'll be nice to have just one continuous video that will hit the points we want to hit. As you saw in the case study, we were looking at a sodium nitrite poison and overdose. And if you could tell for the case study, this is something that we need to take seriously. We kind of get into a mindset with certain ingestions when we go to people they don't take something very serious or they don't take enough for it to actually be fatal. Um, if you have to respond to a call where it's a sodium nitrite poisoning, your index of suspicion of this being a very sick patient should greatly increase. Throughout the presentation, I'm going to be referring to a conversation I had with Poison Control. I actually got to have a phone interview for about a half an hour with a doc over there who's kind of one of the head people at New England Poison Center, and they had a lot of information for us. So, why is it important to be aware of the sodium nitrate poisonings? They're not as much in Maine, New England area yet, but it's up and coming. Throughout the country over the last 2 years, there's been about a 300% increase in this route of suicide. So it has been increasing. It's starting to spread. A very scary part of this is that the toxin that they're gonna ingest, it's super accessible. We will have a slide. It's the next slide or slide after. You can buy about 200 times the lethal dose for $20 on Amazon. Or if you're like a farmer and you're trying to buy stuff for fertilizer, you can buy sodium nitrate through like websites like that. So it's super accessible, it's very cheap, and you really only need to mix it with water to be able to ingest it. But it's so accessible because it's so commonly used. We see it mostly used in the context of meat preservers, enhancing colors in cured meats. It's a really good agent to stop botulism. So that's why we're able to see it. It has a bunch of different uses. It's a highly effective method of suicide. As you can see in our case study, these patients deteriorate very fast. Uh, in that case study, I think time of call to like when they got the patient to the hospital was under a half an hour, and they went from conscious to alert, unfortunately, into cardiac arrest. And this is not a method that's very hard to basically mix the substance to commit suicide. There's Reddit threads that have very specific instructions on how much you need to buy, what you need to mix, what you want to take. So people have laid it out, unfortunately, online in very accessible areas to figure out how they can go this route if this is what they want to do. So what is sodium nitrite? It's an inorganic compound that is used primarily to prevent bacterial growth in cured meats, and it kind of enhances the color. The lethal dose for it varies throughout articles, but what I found was it's most likely between zero point 0.7 to 6 grams, and the cause of death is going to be through severe methemoglobinemia. This is kind of why we are doing a video, because this methemoglobinemia is a kind of a complex subject, and we're going to do kind of a deep dive of not just what it is, but why it's so severe for these patients. And you might have been able to guess that through this case study, the antidote is methylene blue. Once we get to the very end of this presentation, we'll go over it. So sodium nitrite, what it does. So it's going to oxidize the ferrous iron in hemoglobin. That 2 plus iron, it's going to oxidize it to the ferric 3 plus state. Oxidizing is when a hydrogen is lost in a compound and oxygen combines to form a new substance. You can see this basically like in rusting. So essentially, what your blood is doing is it's going to rust. This binding of oxygen with oxidization is not like oxygen binding to hemoglobin to be transported. It's quite literally changing the structure and form of the hemoglobin to methemoglobin. And we're going to do a little more of a deep dive into what methemoglobin is. Another side effect we see of this is the nitrite forms something called nitric oxide, which is a potent vasodilator. It's very similar to how nitroglycerin works. So it's going to vasodilate. Basically, your pipes are going to be a lot bigger. So the volume in there is not as effective. It doesn't get moved around as well, causing some pretty significant hypotension. So just to review normal oxygen transport, we like hemoglobin to be in its 2 plus or ferrous state. You see here that each hemoglobin, and this is key to remember, has 4 different binding sites. The oxygen will go to the lungs. It's going to bind to this hemoglobin sites, the iron sites. It goes to the red blood cell. The red blood cell gets transported through the arteries out to the body, and then eventually the oxygen is released to the tissues. So that's how it should work. So again, hemoglobin, those heme groups, the iron groups, are in a 2 plus or ferrous state. And this is the most ideal state for them to be when they want to take oxygen and onload and offload it to tissue via the red blood cells. Where we see methemoglobin is where that iron goes to the 3 plus state. So where it's oxidized and they're no longer in the 2 plus state, but the 3 plus state, it's methemoglobin now, and those will not bind to oxygen. So methemoglobin cannot carry it, and it will not bind, and it will not release. The other issue is if you have healthy hemoglobin or any hemoglobin where not all 4 sites have been oxidized to that ferric state, they're going to hold on to that oxygen a lot tighter, and they're going to be less likely to release it. So if we go back to this slide, you have some of these groups that are oxidized to that ferric state. They won't hold this oxygen, but you might have some that still do have the ability to hold the oxygen. They're just not going to release it now. The affinity for the hemoglobin to keep that oxygen is so much higher. And this is why we see severe hypoxia in these patients. So what actually is methemoglobinemia? It's a bit of a mouthful, but methemoglobinemia is an abnormally high concentration of methemoglobin in the blood. Usually, this is around 1% in patients or less at a baseline. Me, you, the normal person off the street, that's what your level is going to be. You're usually asymptomatic until about 10%. You may have some cyanosis and your pulse ox may lower a little bit, but you aren't really going to have any symptoms. You're not really going to notice anything. Production of this, it's caused by ingestion of certain medications. So sodium nitrite, which is what we're going to go over. We already talked about where you can find that. Benzocaine, which is a local anesthetic for dental procedures. This was really common in little kids who would put it on too much and would induce hemoglobinemia by using that medication. And the last one is dapsone, which is a topical treatment for acne. So those were 3 super common medications that overingestion caused methemoglobinemia. Another thing that we actually probably could see in more of the rural parts of Maine is untreated well water can build up nitrates and nitrites in the water. And this can also cause methemoglobinemia if someone were to drink that water. This is more seen in like private well systems that aren't held to a higher standard. They're not maintained or tested regularly, where you could see this increase of nitrates or nitrites in the water, if it's consumed, can cause methemoglobinemia. There's a few genetic conditions that also cause it, but we're not really going to dive into that today. Not super relevant to what we're going in about. So the next slide, this looks a little confusing and daunting at first. It's the oxyhemoglobin dissociation curve. There's no questions in the quiz about this one. This is more of the people who enjoy the deep dive into the why things happen. But we're going to break down this graph and try to make it a little more easier to understand. So instead of this title, the oxyhemoglobin dissociation curve, just think about this is O2 binding. The y-axis, this says percent saturation. We're talking about how much oxygen is attached to the hemoglobin. Down here, the PO2 in millimeters of mercury, that is the percent, the partial pressure of oxygen that's in the arterial blood. So if you have hemoglobin that have four oxygen molecules bound to each of the iron groups, and it's in the blood, you're going to have a high percent saturation, and you're going to have a high PO2 because there's a lot of oxygen in the blood and the hemoglobin is fully saturated. This top half of the graph, this is where we are loading oxygen into the hemoglobin. So our saturation, our SaO2, another way to say it, is going to be very high. And so will our partial pressure of oxygen in the arterioles, our PaO2. Both going to be very high in this area of the graph. This is when hemoglobin is going into the lungs, it's receiving the oxygen, it's getting ready to send out to other parts of the body. So that's why you guys see both the PO2 and the percent saturation very high up here. So remember, we are loading. This lower half of the graph, this is where we are unloading and we are at the tissue. So the red blood cells have made their way through the arteries out to wherever their final destination is to offload this oxygen. It's diffusing the oxygen from the hemoglobin to the tissue. It's leaving the red blood cells. So the partial pressure of oxygen in the blood goes down, and so does the percent saturation. Because we've released the oxygen, we don't have as much present now, if any. And that those red blood cells are getting ready to return through the veins back up to the lungs to get reoxygenated. So why does this matter? This is a really good representation of how the hemoglobin, when in methemoglobinemia, is going to hold on to that oxygen. So we consider methemoglobinemia a leftward shift on this curve. So if you look at this blue line, you can see that the percent saturations at these different markings for the partial pressure of oxygen, it's a lot higher. So this is showing us that the hemoglobin is still partially saturated, but it's not releasing to the tissue as much. These methemoglobin have a very much increased affinity for the O2. The tissues aren't being perfused. And the reason why you still see this percent saturation at like a decent number is because we have either hemoglobin that is healthy that still has oxygen and it's just not releasing, or you have those hemoglobin that are partially oxidized, partially not, but they're not releasing their oxygen. All this graph is saying is that when we have this condition of methemoglobinemia, the oxygen is not being released to the tissue, even if some hemoglobin still has it. And this is why we have this cellular hypoxia. Again, no questions on this, but more of a deep dive just into kind of the why. So, signs and symptoms. What are we going to see as depending on how much methemoglobin is in someone's blood? So this chart, we're going to read right over it. Again, we talked about this earlier, where we're less than 10% of methemoglobin in the blood. We might see our pulse ox drop a little bit. Your skin color might be slightly altered, but you're really not going to have any symptoms. When you get to the 10 to 30% range of methemoglobin in the blood, this is where you start to see the peripheral cyanosis. It's going to start out at the fingertips, and it's going to work its way to the core. So you might see more in the 10% range, like the nail beds and lips beginning to turn blue. And as you get to 30, it's just going to start moving its way in towards the core of the body. Patients at this point might be a little confused, but other than that, no real symptoms. Where we get to 30 to 50%, this is where your blood is going to turn dark brown. I think we have a picture of that. We might need to go back a few slides. Oh, sorry about that. It's later in the presentation. Because the blood is being oxidized and like rusting, the blood actually does turn dark brown. So if you were to do an IV and draw back blood, you're going to see an obvious change in color. It's more prevalent where you do like a arterial blood gas draw in the hospital. But yeah, that blood is going to change color. They're going to have trouble breathing, become dizzy, and they might have some syncopal episodes. Symptoms, again, they're going to have the confusion. They might develop some chest pain, palpitations, and become more fatigued or lethargic. Where we get to the 50 to 70%, um, the body's just in havoc at this point. So they can be tachypnic, they're going to enter metabolic acidosis, they can begin seizing and start throwing some dysrhythmias, and eventually they'll go into a coma. Symptoms you're going to see more or less the same as the 30 to 50 if they're still conscious at this point. So that symptom added on is they may be unresponsive or very, very lethargic. If you get to over 70% concentration of methemoglobin in your blood, this is where we see very, very severe hypoxemia that leads to death. And no real symptoms are there. That this is fatal. So this was the picture I was talking about that shows the blood turning a darker color. You can see here, I don't have a normal blood gas to show you in comparison, but this is obviously a very dark brown. The article, I believe, or study that has this picture is linked right below this slide in the notes if you wanted to read that. But some clues that point to the sodium nitrite overdose, if you kind of have someone with vague symptoms that you're suspecting a attempt, an SpO2 that stays around 85% despite oxygen administration. This is a kind of telltale sign of sodium nitrite ingestion. We'll explain it on the next slide. It's actually pretty interesting. But other than that, you're going to see this blood that turns a dark brown color. If you're getting like a blood sugar and IV, you'll probably note that the blood isn't really red. It's that dark brown color. And peripheral cyanosis. So why does the SpO2 stay around 85%? So remember when we put that pulse ox on the finger, it's shooting two rays of light basically at the top down to the bottom, and it measures how much of that light gets absorbed. There's an infrared and a red light. Basically, through this equation, the machine is going to do a ratio of how much of one light is absorbed compared to how much of another. That ratio is converted to the number that you read on the monitor, that is the SpO2. Methemoglobin uniquely reads very high on both of these. So it's always going to be around 85%. You may see it change from like 84 to 87, but you can give these patients as much oxygen as you want. And it's still going to read around that 85% range. It's just because how the methemoglobin reads this or absorbs this light, it's always going to read in that range. So keys to pre-hospital treatment. What you saw the crew in that case study do was basically perfect. They're unable to get an actual airway, but oxygen administration is key. They're not going to be able to do a whole lot with the oxygen, right? But just giving them as much as they can to try and help, you're not going to ignore the oxygen. Appropriate airway management. So if your patient goes unresponsive, we want to try to protect that airway. These patients can begin vomiting, so that could make your airway a little more difficult, but if they have been vomiting, they go unresponsive, and you can secure that airway with a supraglottic or intubate. You're going to protect their airway, and you're going to help them be able to reoxygenate when they either get the antidote, start getting packed red blood cells. So that's pretty key if you're able to do that. If you're not able to, or you're not at the license level where you can do airway interventions like that, be ready to suction, get an OPA in if they don't have a gag reflex, get ready to bag. Loss of oxygen, you're going to need to breathe for them essentially until they get this antidote. In hypotension, fluid is appropriate, but it's not going to be the end-all be-all to solve the hypotension. This likely is going to be solved by pressors until you can get that methylene blue on board. So the nitric oxide, that is a product of the sodium nitrite interaction, causes this profound vasodilation. again, the pipe's very big with the same amount of fluid, so your pressure drops. Adding more fluid to the tank is kind of a buffer, but it's not going to solve it. You want to reconstrict the piping. Levofed is likely going to be your pressor for the medics that you're going to want to use. This is because these patients are likely to be tachycardic from their hypoxia, so an epipressor may not be indicated. You don't want to check up their heart rate. You just want to vasoconstrict and improve that blood pressure. So Levofed is going to be the pressor of choice for us in the field. Zofran, you can't go wrong with it when talking with poison control. Their only concern was Zofran and methylene blue, the antidote, alone aren't big contributors to serotonin syndrome, but combined they could be. And that would just be another issue for the patient. So their guidance was kind of like, if you can avoid giving it, that would be helpful. But if this patient is deteriorating, you're expecting to have to take their airway, and you think that the vomiting or potential vomiting could make it very hard to secure that airway, then give it. But if you can do without, that would be most ideal for them. But then again, you got to kind of treat what's in front of you first. So what's going to kill them first? This overdose and not having an airway, or serotonin syndrome. The overdose and lack of airway would be the number one killer. So you kind of got to run the risk there. Ultimately, the number one thing to do for these patients is rapid transport and early notification. There is nothing that we can give in the ambulance, unless if we got a special protocol to carry methylene blue, to reverse these issues. What we're going to do is support their vital signs and set up the hospital to be able to resuscitate these patients when they get there. You don't want to stay and play. You want to just get moving and try to do everything in route if possible. Obviously, there's extenuating circumstances where it may prolong your scene time, but you really want to be very quick getting to the hospital. The best thing you can do is get them to an ER that has methylene blue and get that into their system. Early notification is also key to treat. You basically want to be walking into the hospital, and they should have the methylene blue basically on standby. So if you give them the time, the heads up for them to get that, it's going to be a big help. Not all ERs have the methylene blue in their Pyxis ready to go. So they might have to go up to pharmacy to grab it. Methylene blue is also commonly used in OB units, so maybe they have to go to their OB unit to get it, but they're going to need a lot of it. And they're going to need time to gather that resource. Doing these things are going to give the patient the best chance at survival. So if you're in a point where you could go to like Biddeford or Portland, and it's an extra 20 minutes to Portland, those 20 minutes is not worth going to a more comprehensive hospital. That likely could kill the patient. So you want to go to the closest facility, give them the early heads up. I was unable to ask the Biddeford or Portland ERs if they have methylene blue in their ER Pyxises, but if you're there and you're curious, you can definitely ask them and see if they do. So at the end of the day, we're going to support these patients' vital signs to get them to the hospital, rapid transport, and early notification. You definitely want to give poison control a call too. So methylene blue, what is it? It's the number one treatment for methemoglobinemia. It has a variety of uses in the hospital, but this is our antidote for this issue. How it works is it reduces that 3+ or ferric iron back down to the ferrous iron, or that 2+ state. By dropping it from a 3+ to the 2+, it puts the hemoglobin back in its ideal carrying capacity for oxygen. So the hemoglobin's going to be able to take 4 molecules of oxygen now, and it's not going to have issue delivering to the tissues, right? So basically, you're just reversing all the changes that it made to the hemoglobin. You're turning methemoglobin back into hemoglobin and restoring normal oxygen delivery to the body. Other hospital treatments, um, they're probably going to also give packed red blood cells. Obviously, not something we can do. This is just basically to give more healthy hemoglobin to the body to transport oxygen if you have an airway established. But this is the end all be all. The only way that this patient has any chance of survival is getting this methylene blue. So I linked these four articles slash journals. This is a lot of where I did my research. And they're also highly recommended by Poison Control if you want to do more of a deep dive on this. So you should be able, they're open access, it doesn't cost any money, it's full articles. If you wanted any more information, you had any questions throughout the presentation, you should be able to just click on these links and it'll take you to the article. You can give it a read. But that is all I have. Thank you for taking the time to listen to this. I know it's not as easy as just going through. Hopefully, I explained everything in a way that was easy to understand. If not, feel free to reach out, text, email, and I will try to remedy those for you. This is the quiz link, same as last month. You need to get a 70 or above. The first few questions are from the case study. I think it's the first three. And then the last seven are from this presentation. And we did hit all those high points for the questions throughout this video. So hopefully it's not too much of a struggle. But thank you again for participating in this training. As always, please reach out with any questions, comments, or feedback. Have a good day.